welcome again, everyone. So the first thing on our agenda after welcome and introductions is the approval of the July 12th, 2023 minutes. And we do have a quorum, and so I'm looking for a motion to accept and second.
So moved, Mahoney.
And I'll second. Or, sorry, whoops. Me or Heather, doesn't matter.
Sorry.
Robin, you got that?
Repeat that one more time. I'm sorry.
Second. Let's go with Marielle.
Okay.
Marielle, you're in my vision there. Any discussion on those minutes, corrections, edits?
I just think the word statewide is all one word in 4. I don't know why there's a dash in between.
Okay. Any other edits or corrections? Okay, thank you, Anne. And with that edit, do we have approval by show of hands? And I know those of you who are on the little circles, I can't see you, but just raise hands. Okay, so moved. Okay, the third thing on your agenda is this is a new term. Oh, Robin, you can lower your hand. There you go. So what we do in the new term is, and I know most of you are continuing from the previous term, but we do have at the beginning of the new term, it'd be good to do a review of the charge. So the charge is found in section 19A-112F. And so I'm just simply going to read that charge. And I'm going to skip over the section that designates who is on the committee because we just did introductions. So I'm actually going to start with B on that particular statute. It says the committee shall recommend to the Office of Victim Services policies and procedures with regard to the Sexual Assault Forensic Examiners Program established pursuant to subdivision 14 of subsection B of section 54-203 and section 19A-112G, which all has to do with sexual assault forensic examiners. The recommendations from the committee may include, but need not be limited to, the following. 1, the certification process for individuals qualified to participate as sexual assault forensic examiners as defined in subsection A of section 19A-112E. The certification process is the SAFE programs training program. That is how individuals become SAFEs. Number 2, continuing education requirements for the maintenance and renewal of such certification. That is the annual competency day mechanism that SAFEs are required to attend annually. 3, the development of quality assurance measures to ensure the needs of victims of sexual assault are met. And that has been our work on the DPH pamphlet, our continuing work on the victim survey and a statewide discharge packet, among other things. And 4, such other related recommendations as determined by the committee. We have asked that the committee consider program expansion and how to achieve that, as well as how to increase the number of SAFEs in Connecticut. And at the end of this, I will be asking under new business if the committee has further recommendations for consideration. C, that was B, this is C. Any recommendations of the committee made pursuant to subsection B of this section shall be presented to the Director of the Office of Victim Services for consideration. The Director of the Office of Victim Services may forward such recommendations to the Office of the Chief Court Administrator. The Chief Court Administrator, in his or her discretion, may direct the implementation of such recommendations as policies and procedures pursuant to section 54-207A. And finally, last paragraph, individuals qualified to participate as sexual assault forensic examiners as defined in subsection A of section 19A-112E shall comply with all policies and procedures implemented by the Chief Court Administrator to obtain certification and to remain in good standing. So that's the charge of this committee. Any questions on this? Okay, so we're going to pick up then with our QA side of things. Number 4, the discharge packet, the DPH pamphlet, and Robin, would you like to begin that discussion?
Sure. Sarah and Beth may have to sub in for me here if I lose my voice. 2 weeks ago, a small group of us, which included Sarah Moriarty, Beth Hamilton, and Amanda Mendoza. Anybody else on here? I don't think so. But also Jesse Gleckel, Susan Maloney, who's from DPH. Am I leaving anybody out? I think that was it. So we sat down in person, amazing, at the offices of the Connecticut Alliance with the document in front of us versus virtual, which is also interesting, and went through it in as much detail as we could. And then the outcome of it was that it was delivered to us by our marketing firm Converge in a PDF version, and we needed it in a Word version so we can actually make the edits that we need to. So I've been in touch with my Converge person. Unfortunately, I've been having trouble reaching her by email because our DPH system was rejecting her email address. So I finally just picked up the phone and called her, and there we were talking to each other. So she said she's going to send us a Word version of the document so we can proceed more precisely with making the edits. I haven't heard from her yet. She had a personal issue on Monday, so I'm hoping she'll come around soon. But in the meantime, we also, and Beth and Sarah and Amanda, please chime in here. We decided that the document, which is 20 pages long, in case you've forgotten, needs to be more in keeping with virtual reality, shall we say. So we felt that we would edit down the narrative in the beginning of the document, and then the section that follows, which is all the resource listing. That may be it for me. Resource listing.
I can, if you want me, Robin, to start talking, I can do that so you can take care of yourself. So we met, and essentially we did a couple of things. So one is that we still are waiting for that physical, like something that we can edit, essentially. What we have as a PDF document, we cannot edit as a group. So we've identified what the edits are. We've identified a way to move forward in terms of what this group talked about last time when it comes to any, places that we would not have to constantly update a list of 50 providers, but whereas the one place that you go to, Planned Parenthood is one of the ones we talked about during our last meeting, that if you go to Planned Parenthood of Southern New England, there tells you every single place that you could get healthcare or get Plan B or things like that. That's what we're doing. There is a place within DPH, and that was one of the women who came to the meeting at the Alliance, that has all HIV testing centers, and anybody who is mandated and participates under DPH, that's all listed in one place. So rather than having, I think it's from pages 11 to 20, all of those resources listed the way that they are, what we are proposing doing and what we plan to do once we actually get this document that we can edit is having one page of resources that lists comprehensively where you would get sexual assault care, where you get STI testing, where you get HIV testing, and then where you would get other reproductive or healthcare needs met. It has Office of Judicial Office and the OBS's branch there. So it's all those big picture things. The other thing that we talked about as a group is that there are some places that we want to add a couple more clarifications around the differences between kind of the charge. When this was originally created, it was created in part because we were doing a lot more work around HIV testing and awareness in the state. There also was a law that was passed that allowed survivors of sexual violence to have, if they believe that they could have contracted HIV during the course of that assault, that they could have the offender, the perpetrator, tested for HIV. That wasn't actually included. So we went back and there's a section there that says, here are your rights. So there's a couple places, like we talked last time about where folks could access reproductive health care and emergency contraception. Those things will also be added in there, but it's going to be about an 11-page document. The way that we envision and what Robin was talking about in terms of the electronic piece is that we offered, and we've talked about this in this group before, I absolutely think there's a need for a larger resource guide, but most people likely, especially if it's sort of like at the time that they might be having evidence collected or seeking medical care or something that is while they're still in crisis, all that information can be very overwhelming. So we also wanted to create a palm size, like a business card size material tool that we could have universally available that has those same 5, when I'm talking about like the 5 or 6 core components of where survivors could reach out for support, it would have references to each of those, right? So it's just, it doesn't replace by any means the larger 11-page document, which will be able to be printed and will be available electronically in full. It just is another quick resource guide to put in folks' hands. And I imagine it could be used, like we have some of these that we've developed for first responders, but I imagine it could be used for both survivors and for providers in terms of getting survivors to the resources that they need. Right now, the hitch in our giddy up, as Robin started talking about, is that we just don't have, nobody has this in an editable format. So we're reliant on the communications folks that DPH consulted with to either get us that editable format or to make the changes, but we have everything lined up. So like everything is ready to go. As soon as we're able to get that document, the HIV folks, the Alliance folks, the other DPH folks, we're all ready to make those edits and we've agreed to what they are. We just can't physically do it yet. So I apologize. Our real hope was, again, in meeting, is that we could have this all done by the time we came back together, because it really is. I mean, it's just procedural at this point. There's nothing else holding it up. But we just unfortunately haven't been able to get it. So we have worked on it. We, all understand what we need to do in order to get it done. We just need that. We just need to be able to make the edits.
Thank you, Beth and Robin. It sounds like this has really, though, come a long ways since the last time we met. I have somebody who with a raised hand up here. It says judicial.
Yeah, you could just ignore that, Denise. We're not sure
okay.
why that did that.
Okay. There we go. Sorry about that. So thank you so much. Robin and Beth and Amanda, what is the likelihood of being able to have this ready to go for like November, like the November meeting?
I imagine it's about an hour of work on all of our parts once we have the editable document. So I don't see any challenge with that whatsoever. I want to say, though, I can't speak for, and I don't know, Sarah, if you can, or if it's like a, maybe we ask Robin if she's available to come back on. But the process internally for like when DPH prints and approves that internally, that's nothing to do with the Alliance. So I don't know if there's a longer, if it has to go back through an approval process or anything like that, or if they have particular vendors that they'll need to work with. So in terms of the content being done and you all being able to see that content, I absolutely think so. I just am not fully aware of what DPH has to do to produce it, if that makes sense.
So this is Robin. I'm back. I'm sorry. I just got a message from Lori Johnson at Converge that she'll be able to send us the Word document tomorrow. So what version is it in? Amanda, you knew Canva or something?
Canva, yep.
Canva, okay. So so that's coming to us. And originally it was that it would all be formatted. It would be in a document that can be printed, but that we DPH didn't necessarily have the funding to print it. So we'll have to check back to see if that's changed in any way. But I think the idea was that we would, anyone who needs it would print it as needed versus printing hundreds of documents, which is kind of passé right now. But also the contacts change often now, and we don't want it to be out of date when we've printed it. Even for the HIV group in our department, they are going to have all new vendors as of January 1. So we don't want to print the old vendors and then January 1, it'll be out of date. So that's why we thought we would go to the version which Beth has just described.
So it sounds like, though, you know, I'm really, like I said, I'm impressed with how far this has come since our last meeting. So it really sounds like we're beginning to look at being able to wrap this up and get it out there, which is a great thing. But any other comments or questions about the pamphlet?
The only thing, Denise, I just want to quickly clarify is that the Alliance agrees to take on both the hosting of it. I think it can be linked to other places. We also will take on the cost of printing the palm cards. So I don't know that we have the resources to print the full 11-page booklet, which is going to need to be folded and somehow sealed together. But we can absolutely print palm cards so that all the, again, those resources can get to victims. And then it can also have a link back electronically to the full 11-page document.
Okay, that's wonderful. Ann, did you have your hand up?
Yeah, I did. I just because I haven't seen this. So is it also going to be published in Spanish? And what about people who are legally blind?
As far as I know, there's no resources that have been dedicated to doing that. We likely could. So the consultants that we use for communications do all the Spanish language, not legally blind. I can't speak to that. But I know in terms of Spanish and sometimes Portuguese, those are ones that we're able to get. So I might be able to figure out having that done. But what it would also require is then reproducing, because there's about a 30, sometimes a 40% increase in text amount when it comes to translating to other languages from English. So it would really require a full redesign. So I don't know that we have the resources to do that, and it's not necessarily our document, but I don't think that that's been planned also for DPH.
Do we have any sense as to how many people are in the population of Spanish language only or Spanish language primarily?
You know, we've looked at that as a coalition. There's actually different stuff. There's some stuff to say that there's more people who are dual lingual than there are people that are monolingual within Latin communities. I'm honestly not sure. We've seen some different research, but I could try to find more information to bring back to you. I'm not sure.
Okay. I don't know what to do about the legally blind people. I mean, I don't know if you
I
can
don't
make
know.
something braille that small.
Well, the other thing is, on our website, everything, so we have a thing called Recite Me. So everything is accessible in terms of screen readers, like all that kind of stuff. So when it's hosted on our website, there is an ability for it to be not universally accessible by any means in terms of print, but there are ways that folks could get that information read to them through screen readers and others. That might be a helpful piece.
That's good.
Yeah. So I think, though, that once, you know, the primary goal right here, the immediate goal, is actually to pull this together, and then we can look at how to expand that beyond the immediate English version, and you know, how to answer the question of, because it's not just Spanish. It's, you know, I know that we have Polish speaking. I think the judicial branch had Polish as one of the top 3 languages in the state. So so we'll work on getting all that and the answers to that as we go further down the line. Any other questions? Okay. So has everybody had a chance to look at the victim survey? Because this is also, you know, the victim survey, the discharge packet isn't just about the DPH pamphlet, although certainly that's been a centerpiece. But we also really want to expand that outwards to become also a victim survey, to include a victim survey as well as other information. And I apologize if I seem a little distracted. I've had to turn my phone over because I'm getting phone calls. But in any case, so let's talk about the victim survey. And and hopefully everybody's had a chance to look at that. So my question then is, well, first of all, a statement. First of all, this was developed, kind of sort of putting it in context, this was developed for the SAFE program, which is why it's specific to SAFEs. What we really want to do is take this and take SAFE out of it and really make this adapted to all patients who report a sexual assault, whether or not, what kind of provider they had. Marielle?
I totally understand the goal, but I'm thinking it's beyond the charge of this committee to transition this survey to something that would go beyond the SAFE program. So maybe it's something we transition to the commission. I'm just thinking of the charge of this group.
And do you want to, do you view this as something that would come out of the purview of the commission? Because we can certainly transfer it to that.
I think Marianne's right. Like, this is SAFE, so it makes sense to bring it to the Evidence Commission and have a discussion of it there. I think maybe that group can wait until we see what we get for results out of this.
Okay, and so just limit this to SAFEs across the state.
Mm-hmm.
Marielle,
Yeah.
Is that what you were thinking?
I mean, I guess I know the point of the survey right now is if you go to a SAFE participating hospital, this is administered to them because you wanted feedback for your SAFE program.
Yes.
And I understand that. And I understand what the thought is we want to get broader feedback from all who are having kit collected, right, to get the same kind of survey feedback. I just don't know that it falls under the purview of this group to be the sole arbiter of what kind of that survey feedback, what kind of survey we'd want. Because maybe it doesn't play exactly to, and Denise, I guess my other question is, you're saying, are we only going to administer this to someone who saw a SAFE and did an exam, or are we making a survey that would go to any person who reported to a hospital, whether or not the hospital did the survey using their own staff, which we know the Connecticut law allows, or are we only going to administer it to somebody who saw an actual SAFE to evaluate the SAFE's training? So I guess those are my questions. It's like, I feel like it's almost a little beyond this group unless we're limiting it only to SAFEs. Because then that does kind of more follow under this group because you guys train all the SAFEs in the state.
We can certainly limit it to that, but it was part of a discharge packet where the DPH pamphlet would be like the centerpiece, because that's also not limited to SAFEs either.
Right. So, we have to be very clear on what we're trying to include in that packet and where that falls to.
Beth, do you have a thought on this? I can see that you're mulling it over.
I see the steam coming in. So I mean, ideally, right, in an ideal world, you're getting more data, more information from more folks. So like, I would really support, I think we've done a great job of using it within the SAFE program. I think it's not utilized as often as it could be. Like, I wish we got more respondents, quite frankly, or more response. But I do think it would be helpful to have a more universal tool that could capture data and trends. And maybe it doesn't replace what we're doing with the SAFE program, with those 9 sites, but it is something that we could get more over survivors' experiences, because that's who's answering it, right, across the state. And some of what I would really appreciate personally is that we see a lot of information in the coalition, which Denise and I have been talking about, like the impacts of whether or not somebody's at a SAFE hospital versus being at a hospital that does not have that program. There's really big disparities, right, oftentimes in the survivors' experiences of that. Having data that can demonstrate that, I think, would be really helpful to thinking about policy upstream, would be helpful to thinking about how we make the experiences universally better of all survivors throughout the state, and part of that is about SAFE training, that we're trying to spread that. So I would be a proponent of making it larger. The one challenge we've talked a lot about internally is like, survivors don't know what they don't know. So the nuance of being able to say, like, was it a SAFE, was it not? They're not going to be able to do that. One of the things I think you would have to really focus on is requiring somebody to say what hospital it happened at, what it was the evidence was collected at, because I don't think survivors are going to be able to like capture who's doing it, or they're going to make assumptions and get it wrong. So that's the only thing, is like, we'll have to be careful about how we collect that data, how we ask the questions, and what we require to be answered. But I think it'd be great if it was universal.
I mean, I almost, Beth, like, I'm totally in agreement with you on all those kind of logistical thoughts, because to me, if we're going to ask all of them to weigh in, it does need to be a totally different type of survey, I think, than how this one was originally, because this wasn't the purpose of what
Right.
this one was created for. And I almost wonder too, if it's less about the discharge packet and more about maybe making it part of the kit, so that, you know, it's really given to the person in the moment to say, we really hope you will give us feedback on this experience. So I don't know. I mean, again, I think that's a discussion for the larger group of the commission, rather than, because maybe you won't get nearly as much if you don't send these people, if you only send it home in a discharge packet, they may never look at it again. But if it's part of the kit collection process where somebody has to highlight it and bring it up and really shove it in their face, I mean, I'm saying that in a really crude way, but, you know, maybe we get the kind of data and feedback we need and the participation we need. And if we create it in a way that makes it easier for them to answer, I don't know. I mean, I'm for it. I just feel like I don't know if this is the place where it belongs.
So Anne, I'm sorry, are you okay?
Yeah,
Sorry.
my wincing is when I think of this as part of the kit, I don't know where this is going to be deposited, because arguably if we're having a victim fill it out and they're making any kind of statement, then I could see a defense attorney saying this is a statement by the victim that they think they should have access to, which
Okay.
would really make me cringe. Because there's a section in here about how they find the police response to them,
Yeah.
which is not talking about a friend safe. It's talking about a police officer.
I wonder if one of the like intermediary steps that we've talked about also is just, one is I do agree there could be like more prominence, right? Or just a highlighting of it verbally, that could even be helpful. But even if we were able to include like electronic links, I think we might even just have more buy-in. Right now, what happens is we give self-addressed stamped envelopes, right, to the OBS program. They then are giving that out when it's happening. I think some of that is a little bit antiquated, right? Like for some people that's really going to work. For many of us, it's not. But I do wonder if there is a way to think about perhaps an insert or a postcard size or something like that that could just draw a little bit more attention, but that really also gave folks the opportunity to electronically, like to save it on their phone and think about it later if they want to. The thing to know about all of these, though, overall, I really want to say is that what we get are great experiences and terrible experiences. Like we don't get a lot of the stuff in between, you know, and it's important. Like you want to know those things, but that's who responds. And that makes sense, right? That's universal. That's not just us who's responding. So I do think I totally appreciate and did not really consider before fully your point, Anne. I think that's a great point. But I do think there's a way that we could do some better, flashier insert, or at least like just getting that electronic survey to folks to increase the number of respondents that we have.
And I guess the other question too, Beth, what you bring up is right now it goes to OVS because they oversee the SAFE program. So there was an absolute destination of people who wanted the data. Where does it go from every person, right? Who has a responsibility for obtaining that data and collating it and sharing it with the necessary stakeholders who care? It's a bigger conversation.
So what we do right now is the Alliance actually it's all done through SurveyMonkey. So if we get them in person so that we can keep these large electronic records of everything, every single thing that we get verbatim is typed into SurveyMonkey at the Alliance. And then we give quarterly, or sometimes we don't even get some in a quarter, but we give sort of those updates to OBS in terms of here is a full, they get everything we get essentially, but it's all done through SurveyMonkey. So it's just a bit more tight and organized. We are happy to. So one is, I don't know if this is appropriate or not for the larger group of the discussion, but we're happy to continue to do that for whomever. So if it becomes a matter of like procedure, like somebody needs to host it and have it somewhere and then feed that, it's not publicly available, but feed the information back to whomever, we're happy to continue to do that, or we're happy to not, you know, so like whatever works.
This document we're looking at is some people actually do the survey through SurveyMonkey.
Nope, they give us papers, they send paper back to our office. We go in because it's just a better way to keep track. It tracks trends. Like they can pull out reports that are just, it just makes sense. You guys are
doing the data input on the SurveyMonkey. I got
yes. It. And I should say that the Alliance for all these years has been incredibly generous to pay the postage for this. I want to say publicly thank you to the Alliance for doing that. And I do see, Ann, you've got your hand back up.
Yeah, so the comments made by victims to their the Alliance counselors are covered under the statute. They're confidential. So when they collect all the data, then it can be, I don't know if aggregated, whatever the word is. So it's not giving the identity of whoever it was, right? So the issue is that, which is what this is geared towards. It's not geared towards this individual patient said they didn't like their nurse or they were upset with how the police handled things, because then, of the small percentage of these that we actually prosecute to trial or prosecute, we'd be in a position where we're going to have to hand that over if it's an individually identified person. But it seems like this is meant to get a group opinion, and it will vacillate wildly like everything else. And I think in terms of whether we do this for anybody else, that's a discussion to take at the Evidence Commission. But just for here, I think this is pretty good, pretty thorough. I was a little concerned about the reference to the police. And number 9, I was given adequate information about follow-up and referrals. The definition of adequate depends upon whoever is answering it, and referrals, I'm not sure everybody understands what referrals means. That's my 2 cents.
So, but it's a good 2 cents. We know that as far as the actual survey, we know that is what we started out with. We know that there's always room for improvement, and actually that was one of the things that we were looking in. Obviously the audience is very important, and not when I'm talking about audience, I'm talking not so much about the victims as I am talking about whether it's safes or everybody, and who it's written to reflect. So I think that's incredibly important. But if you take that aside, there's a lot of work that could be done separate and apart from that. Like what kinds of questions, what kind of data would be useful in helping us to provide better services. I think that's perfectly appropriate for this group, because you can take that, you can utilize that for safes and say, okay, here's, the care of a safe. What should that care look like? And then at a later point, that could be actually modified and edited to be more appropriate for a statewide. But we're probably looking, I think what we're doing is we're looking for a starting point to really make this a tool that could be utilized across the state ultimately. I mean, this is a great time. We're working on, a year from now, I would expect this to have a new set of technical guidelines and a new kit. And why not have a victim survey that through the commission that goes right along with that? But the work it doesn't just have to be limited to one agency. We could take what we have for safes, look at what's actually in the survey and say, okay, thinking about safes, is this appropriate? Does it need to be changed? And then we can take that, once we call that down, and make those changes, then we can look at, okay, how do we, through the commission, how does this, what would this look like statewide? Does that make sense to everyone?
I mean, I don't see the in-between, I guess. I have a harder time picturing just asking about safe performance, because to Beth's point, we can't rely on the person who's seeking the evidence collection to discern whether or not they had a safe. So even though they've all been trained by OVS, I get how we would ask through this because we know they saw one of your safe program safes when it's handed to them. But if we don't do, if we try to do an in-between, so there's statewide, right? Then there's the in-between just about safe performance, and then there's the safe program safe performance. I just don't see how we accomplish the in-between, because I just think it's asking a lot of the person who has to fill out the survey to be so aware of what, what they experienced when they were at the hospital. And I don't know that that's, I don't know if that's as doable. To me, that's my opinion.
Won't they have their discharge paperwork with them though that would allow for a trace back to see if it was a safe?
Again, asking them to have to do that, I just feel like we're putting a lot of onus on somebody who's had a horrible experience and may or may not even want to take this survey. I don't want to make it more challenging. You know, it should be very simple. I just don't know that we could do an in-between. It's either going to be a statewide type of survey, or we keep a statewide when it's not done through the SAFE program, and the SAFE program has their survey. But I don't know. I just don't see an in-between.
So question for you, Marielle. How would you, let's talk about in terms of the outcome being, at the end of the day, the outcome being a statewide generalized survey that's very simple to take. Now, I think, if I'm hearing you correctly, this should be done through the commission. Yes?
I think the statewide deserves, I don't feel like this committee should be responsible for that, because that's not the charge of this group. We're focused on the SAFE program here in Connecticut and the training of SAFEs in Connecticut. The other experiences, I feel like, fall outside of this purview. But if you all disagree with me, that's a whole other ball of wax we can get into. I just see a more statewide generalized survey to be something that would fall, I think, under the commission. Maybe it's a subgroup of the commission, but I don't think it belongs.
Oh, I was actually thinking, oh, here's another work group, Ariel.
I'm just saying it didn't have to go that route, but I just don't know that, this group might have enough to do on our own. I don't want to put something on this group's plate that really belongs maybe elsewhere. I don't know. Do others agree with me that they would want to be in charge of a statewide survey when they feel like their charge is to talk about the SAFE program here? I don't know. I'm just trying to keep clear lines of what each of these groups, has responsibility for.
So for me, I see some interplay between both. I mean, because I think like the SAFE program, right? While I totally agree with you that like it's going to be different in terms of those 9 participating locations and the training and the response and all that for that particular area. But I do wonder, and I don't know what this looks like exactly, because I'm like thinking through all this as you all are saying it, and it takes me a little while to process information. But the way that I think we're trying to move towards an understanding that everybody is receiving some level of training from the SAFE program, and trying to possibly identify ways that we can pull some of that data, like the efficacy of that, just how SAFEs are doing overall, knowing that OVS is providing that training sort of, upstream. I wonder if there is a way that like it's a subcommittee of both in some ways, right? Like I do see an interplay between the SAFE training that's happening for folks statewide. And then I really understand also, I do agree that it does come under the purview of the commission, right? But I wonder if it's like an agreement between, and there's a responsibility in both ways. Like I kind of see it both, but I wonder if there's a way to say like the 3 of us from this are going to sit on the evidence commission, like are going to be the folks who are going to be on that subcommittee. So there's really clear communication like between both of them, and that whatever we're doing, it's exactly the same in both places. Our understanding of our work or our charge is the same in both places, if that makes sense.
So, Anne, I know you kind of went off camera, but would it be possible for us to add this? I mean, we have a commission meeting coming up. Can we just toss this over to that? She may not be able to respond at the moment. So why don't we agree to do that? We'll table it here. Is everybody in agreement with that? Beth, is that okay with you?
I'm happy to table. I mean, Denise, did you have like Anne's point, I mean, there was some good feedback for you, right? If you're going to continue to use this survey until whatever time you might change over or something. I mean, do you need more feedback on this from the group? I don't want to.
Well, I think to your point, and I think that it doesn't make sense to have a go-between. It's like we've been using this for so many years now. And if we're looking at changing it to something statewide through the commission in the next upcoming months, then it would make more sense to go straight from this to that versus something in between. Does that make sense?
Are you going to still for the program itself, aren't you still going to want the feedback you're receiving? Or do you feel like you've gleaned as much as you're going to glean over the years and you don't mind going more broad on a survey? I'm just trying to get a sense of the program.
Yeah, no, I think that it's fine to actually continue with what we've got, because to be honest, and I think Beth, to your point, we don't get very many of these back, do we? No. So I think it's better to wait for that change and then be more broad-based about it.
Yeah. Knowing that we're going to face the same challenge, probably, right? You know, how
Yeah,
much
probably.
can we really get back? But I still think it's a worthy thing to look into and try and do. So.
Okay, so we're going to table this topic here. Okay, for the minutes, we'll table the topic here. We're going to move it over to the commission, and we will continue the discussion at the commission level. And that's what the wonderful thing about these groups is you have, for anybody that doesn't know, you have the Safe Advisory group that is entirely about safes and safe practice in Connecticut. You have the commission that has the oversight of the technical guidelines and the kits. And then you have the Sexual Assault Kit Initiative, or SAKI group, that it was really more about kit tracking, and all of these groups fit together to form a whole. And so each of us has a role to play. And I say that by way of explanation to anyone that does not really know what we're talking about here. So moving on to the next one, which is really a request from input from the committee. What we are looking for, we had previously asked the committee, and this is switching gears entirely. We have pretty much asked this committee in the beginning of this year to really help to advise on how to increase the number of safes in Connecticut, what the issues are, and then as time goes on, you know, and we're talking about over the next few years, what an expansion would look like, what, you know, what model would that look like? What would be the resources that are needed? What are the considerations? And so I'm going to look to the committee, and that's what it says, request. It's a request for input from the committee. So I am going to ask, I'm not going to put anybody on the spot, but I am asking the committee to provide voice to your thoughts on this topic.
Denise, maybe we're at a moment where we can give everyone a second to ponder that, because a call did come in on a case and that came to me. So if I could borrow you for 60 seconds to fill you in on that and give everybody a moment to ponder your larger question.
That would be to me?
Yes, I'll be down in just a moment.
Okay, sorry about that, folks. I'll leave you to think about it for a moment.
I have a question, and I don't know if folks could answer it here. But when Denise is saying like the expansion of the SAFE program to go statewide, is the intention that every hospital in the state, if participating in the SAFE program, that would mean that there would be enough nurses on call to go to any hospital, or that each hospital would have trained SAFE nurses, but they're not necessarily on call to travel? Do we know if there's a differentiation between those two?
I mean, I think the intent from the beginning was to have all the hospitals be able to activate the SAFE program when they needed it, right? So, but the problem that they've encountered over the years, Amanda, is that they don't have enough people interested enough to staff up the program in order to allow that system. So to your point, though, I kind of am still a little unclear myself on whether OVS is still trying to move towards that. I think they're not, because I think they've realized that no matter how much money they have to throw at people, they don't have interested people ready to work for the program. So it's sort of transitioned to that other scenario you've described, which is trying to get the hospitals to train their own staff. And I think, you know, so we're in a bit of a hard place as a committee, because, you know, there was the goal, the overall goal, which would be so much easier, not only for the hospitals, because they would have the one-stop call shop, right? And say, I have somebody here, you know, can you send somebody? But even for the participating hospitals, the struggle for them is they could call but staffing may still not allow for someone to be sent out when the call has come in. So, right now the SAFE program, even for the participating hospitals, doesn't get to do every call every time. Although I think it's pretty good. I think they've shown data over the years that they cover a lot of most of the calls they get. They don't cover every call they get because sometimes they don't have the staffing for that either. So I do think we're in a place where, I don't know that the realistic vision is that statewide ability to activate, the SAFE program for every hospital. And so, to your point, when Denise gets back on, I think I was going to sort of ask her, like, what is the new goal? Do we have it, or are you asking us to come up with?
Right. Okay.
I mean, I think some of the other challenges though is that, and I don't think in my recent conversation, I don't know that Denise is going to have an exact prescriptive answer for like what we're thinking. I think we're 10 plus years past the inception where we thought for a time it was going to look a little different. We switched to this training place and now we're trying to figure out like, there's such disparity still that exists. And I know we've talked about this, Marielle, like, in terms of like when somebody is going to a SAFE participating hospital versus when they're going somewhere people are trying to figure it out on the fly, right? And maybe they've gotten some training and maybe they haven't. Like there's such a disparity in not just how the victim feels and how they move through and that experience for them, but even in what happens with evidence, what happens with the cases that moves forward. So no matter what, I think we have to figure out how do we get a minimum standard of both care and like compliance is the right word, but like, how do we do it in a way so that everybody can have a universally good outcome or possibility of having a universally good outcome versus what happens now.
Sorry, everybody.
Piece of that,
my apologies. We were talking about phone coverage to help monitor these phone calls, and I think Mary just saw an example of what happens with the phones. So where did we leave off at? I think there was some conversation going on before I go back to asking for input. Was there any other conversation that should be shared?
We were just asking for sort of clarity around what, so I think that there's a couple ways to think about it, both in terms of like, is it that we would want, and maybe you don't have the answer to this, and that's what we were sort of parsing
that
through.
Would help
but like,
if I had my that would help if I had my volume on, right? Did everybody hear me or no?
Yes.
Yeah. So
Okay.
Denise, just so you know, when you stepped away, the thing we were asking kind of across the group was clarity on, is the question whether or not we want to expand so every hospital is a participant, like the 9 sites are, everyone has an official SAFE part of that response program where I call the SAFE program, and as they largely are able to, they're going to respond out and have a trained SAFE? Or is it that we're thinking about every hospital needs to have SAFEs who are trained, designated at that hospital and available, but separate from the kind of response program that happens currently in those 9 participating hospitals? Like what, I guess more nuance on, or more of an understanding of what the question is.
I mean, we were sort of saying, Denise, that we realized that, as we've had a discussion, you've sort of said we could have all the money in the world right now, but we still wouldn't have enough interested people to service a statewide approach to this program like we hoped from the inception.
Yeah,
right?
yeah.
We've gone long enough to know that right now we just don't even have enough interested SAFEs in the state of Connecticut that are willing to work, the hours that this program probably requires and the on-call nature of it. So when you ask us what are our thoughts on the program, I think we're struggling to know how to give you feedback without kind of knowing whether there's a newer sense of the goal and what that is. And I think before you popped on, and maybe this will help Amanda too, is Beth and I were talking about, so the state law doesn't limit who can do a kit from a healthcare perspective because they don't want to limit access, right? They want people to not be struggling to get a kit done when they report to an emergency room at any hour of the day. But what we're realizing now is that we have a SAFE program that has rolled out and provides probably that better standard of care because they're so much more well-trained, but we have hospitals that still aren't required to have SAFE on staff. So you may not get a SAFE at every hospital. every time you're there. And even at hospitals with safes, you may not get one 24 hours a day. So we have that struggle, right? Do we try to, as a state, limit, do we try to change the law? Is that the answer? I don't know, because that would maybe limit access. And I don't think, we ever wanted to do that. But we are at a place where we want more safes. We want every person to have a safe experience, but we're not there because it's A, not a law requirement, and B, we don't even necessarily say we can do that. There might, to your point, Denise, you've made this point offline, not everybody wants to be a safe, right? So how can we make healthcare providers at every institution have to be one?
So any other, just, and before I jump in, does anybody want to tag on to that? I mean, Amanda, your hand is up. Was your hand up before? Is that a new comment?
No, I think I was second. So I want to let other people speak before. So I'm still gathering information, so I'll go last.
Okay, Heather, I see your hand is up as well.
I apologize. I don't know how to get it back down. So if it stays up, I will try to work on that. I was just actually typing.
That's okay.
I'm not on my normal computer with no camera either, so I apologize.
That's okay.
So I think a lot of it too is these nurses are, mostly probably full-time, or they have full-time jobs and a part-time job, and maybe child or parent care issues. So they're just not able to commit, the time that's needed, because it's a time-consuming process too. So it's just, I think it's tough recruiting anyone lately. And, like the ENA, we're also struggling just to get new members, and people just, they have other stuff that they're preferring to do, or, they're just not able to commit the time needed. Unfortunately, it's sad.
And even I would raise my hand. It's Karen, but I can't figure out how to do it.
That's okay.
But anyway, what we're finding, even at Yale, where we have a great number of trained people, just the nature is that, the patients are coming in, on Friday and Saturday overnights disproportionately this time of year with the schools back in session. But also, could be a Tuesday morning and you get, two at the same time. Generally what we do is we try to always have at least one person on a shift, and then that person's moved in over to from whatever responsibility they've been assigned to go and take care of that one patient. And then there's always somebody else who can be moved over to take their spot. But then you have two at the same time, and, might not have any all week, and then you get two at the same time. And so, well, that's the difficulty we're running into, even well-resourced.
Yeah, I have made the point to others that, as in the ideal world, every victim of sexual assault would have a safe. But in this day and age, in particular, as we're still coming out of the pandemic, that's not realistic. It's not a realistic goal. I'm to be honest, I don't know if it's ever possible to actually do that, unless somehow not that I would ever expect this to be the case, but from my perspective, about the only way that you could ever have that happen is if it was a requirement to be a safe to work in an emergency room. So, but that's not really realistic either. So I think, and I've said this before, I think the best case scenario is, and I have asked for input, but I'm just going to throw out this observation. I think the best case scenario is to continue to hold these classes, to continue to recruit from every hospital, every class. And I know I can tell you, Marielle, some of the ED managers are already getting a little testy because I keep reaching out to them for every class. But I want to make sure that everyone has that opportunity. I don't want to not invite somebody to send somebody to class. Yeah. So we make every effort to cast our net wide to everybody possible to invite them to send staff to train, in the hopes that over time we will build capacity, and ideally every hospital would have safes but I just feel that, yes, it is. Heather says it's a time-consuming process, and it absolutely is. One of the managers was telling me that the course is too long, and I get it compared to some of the other courses, but the reality is we don't control that. If it's an accredited course, we don't control that it's a minimum of 40 hours plus clinicals. So we just have to educate people that that's what it is and that's why it is, and keep trying to get people into the program. What I'm hoping for, though, is a conversation where we have the different perspectives of all these different groups, and from each group's perspective, and Mariel, you and I have had these conversations, Beth, you and I have had conversations about, and let me put it this way. What I find is that each perspective contains information that another perspective does not. And if we add those perspectives together, it makes for a more, what I think of as a more robust understanding of the big picture and how to move forward in light of that information. Sherry, I know you've been involved. I don't mean to call you out. You've got your hand up, though. Did you have?
Yes. Hi, everyone. I'm sorry I was a little late too. While you're thinking, when you're saying this and knowing that the course is long, I think one of it is, yeah, in any of the academic programs that we're putting out registered nurses, bedside nurses, they're not getting this information. That it's not, we can say it's very touched upon, but at the end of the day, they're not getting this information. So how do we, it's like a twofold, and I don't have the right answer, but legislation says this course is, and it's an excellent course, don't get me wrong, but is there a way to think that the course could be more of an immersion to have versus spread out? Because it could be, at least the didactics, but then also, is there a way to get more interest that each academic program that's undergraduate, that's getting these bedside nurses to be, here's like, a 6-hour curriculum, something that, would have to have conversations with academic programs, but we're not talking 40 hours of something, to at least get them the basics. So when they get out, maybe they're not all going to the emergency department, but then that's actually generating some more interest. But I know that when the students are getting out, even if you're saying it once, they don't understand what a kit is. They just really don't. And then and then if you're in the emergency department and you're training someone, they come in with you. Then you're taking 2 people up, but they do need, so I don't know is how to expose them earlier on or during orientation. And that's a whole nother, so there's just ways to get them earlier on understanding at least the basics that maybe they would have more interest in the course. And I don't know if you've looked at the course and said, is there ways to offer it in a more condensed version and then do clinical or something like that? Those are just some ideas.
So I'm wondering if you and Kim could have a conversation about, I know Kim is in the middle of a course, so don't, we'll get past the course. Maybe have a conversation about what that might look like, that we could bring to the November meeting, a little bit more information about what that could look like.
Okay.
I'd love to have a conversation with you, Sherry.
Sure. I can send you my email, Kim. I'll throw it in there, the chat, for you to see, and we can set up a time.
Thank you.
Yeah, and Amanda, I'm looking back at your hand. I'm sorry, you've been waiting a long time.
No. It's important for me to listen and try to gather more information. These aren't really full, complete thoughts. They're more questions that are I don't know, just to get us thinking. So one of the first questions that came to mind are what are the barriers for safes, to become safes? And at least in regards to on call, I'm thinking, it's not a full-time position. It's not, right? It doesn't have benefits. It doesn't have things that people look for typically for stability. So that was making me think what if there were full-time positions of safes, at hospitals, and maybe they're I don't know if they'd be employed by OVS or not. I also don't know how many hospitals there are or how many safes realistically should be at each hospital. But I'm just imagining in regards to someone being interested. Like a hotline is difficult to advertise and to be something desirable to want to do, especially if you're trying to find something that is more, has more stability, has benefits and things like that. Granted, I know it might still involve like overnight sort of stuff, so that can still be difficult, but that may be something people are interested in. So that was one question I was floating in my head. Another question I had about in general with the SAFE program are who are these kits currently not accessible to? So that makes me think of, you know, transgender patients, non-binary patients, intersex patients who may currently right now not be going to any hospitals given, you know, any sort of medical trauma that they might have. So when thinking about expanding the SAFE program and like whether it should be in emergency rooms, like that's just like another thought that I have at this moment. Are there other people or other institutions that should have kits available to them for people, just in general, just a thought. And I think that made me think of and someone brought up academic, which was also making me think of like colleges and such too, if there was any way for folks to get education beforehand when looking for work, because then that's another, I don't know, stepping stone for folks to have more training to then go to a hospital, and they're now employed and SAFE trained. So it's not like they have to be pulled from their current job to now do a 40-hour course to now be SAFE trained. So maybe looking at before people are then hired to go to hospitals and such. So those were just random ideas that popped up, questions that came up. I don't know if they're helpful, but yeah.
Well, they were.
Okay.
They were. Karen?
Yeah, so I think it's, you know, in terms of spreading the word and trying to get more nurses to, especially nurses, but also it could be physicians, it could be whatever, to be trained PAs, nurse practitioners, is, you know, thinking about what currencies matter besides money. And I know one currency that can matter is awards, you know, sort of publicizing, you know, people who are doing good work. And so the one thing that we could do is make sure that we nominate, many hospitals I'm sure we have Nightingale Awards, they call them, but, you know, and then the nurse gets their picture on a big poster, and it's posted in all the public areas, and it's announced, and their nurse managers, et cetera, know, and they are likely to be considered more for promotions than somebody else. So, seeing if we can nominate those who are SAFEs, to make sure, nominate them to get awards in their hospital. You know, same thing for any PAs, and that will also then, you know, reward those people who are doing the good work, but also attract attention to the program.
I think that's a great thought, actually. And you're right. And you know, when I look at resumes and I see Nightingale Award, I mean, that really stands out. So that's I think a good idea. I do want to go back to Amanda. You were talking a little bit about, can they be done in other places? And I know the rest of it we can talk about, but it's and Mariel, I know you probably know the law better than I do on this, but
that would require a law change.
Yeah,
because legally the statute requires kits to be done at an acute care hospital facility. So, and
that's solely an emergency room. Yeah. Okay.
Acute care is emergency. Yes.
Okay.
And I know Denise had thrown this out in another conversation about, and again, it would require a totally different legal framework here in Connecticut, but having regional centers, right, that are purely for the purpose of receiving crisis care and kit collection, whatever. And I'm totally open to that thought. But again, that's such a broader goal that would require many more years and lots of change. So, but along the same lines of what you were thinking about is like, is there another setting? Yeah, there might be. I don't know. And Denise, I'm sort of going to throw a question in here that might tie into this. Like in other states that have state programs, for instance, we know Massachusetts has one. I have no idea at this point. It's been so long since I've seen a preview of their program. Do they operate statewide? I mean, do they have the same struggles? Do we know what they're doing? I'm kind of wondering if we know what some other states are doing, and we don't talk enough about that here. And I'm sometimes interested in learning from others.
Yeah, I can certainly. And Heather, I'm just going to, on a side note, Heather, I know you have your hand up. I don't know if it's still up or not, but I'll give you a chance just a second.
I don't know how to get it down.
Oh, okay.
Let me try and hit this again.
I just want to make sure you weren't left hanging there.
No, I'm sorry.
That's okay. So Massachusetts, I talk to the director of the Massachusetts program on a fairly regular basis. And first of all, they're based in the Department of Public Health, and they do have a $7 million budget, their own line item. Okay. So that by itself is a vast difference from us. But with that said, they have 65 hospitals. They're currently in 40 of them, in spite of having almost 3 decades of experience. They're only in 40 of them. They've had the same challenges. And in fact, their director, she said, you want to talk about being under a microscope. The microscope is, you have a $7 million budget. Why aren't you responding to every single case? And so it's been a challenge for them, and they have the same challenges as we do, in spite of that budget. They are going to Telesane, but they again have $1 million. They have, and not only do they have the line item, but they actually get grant funding. And I have toured their facility, which is $1 million facility. But they have what was described in our last meeting, which was a couple of months ago, as a 3 to 5 year plan to get to all 65 hospitals. Mm-hmm. So, yeah, I think sometimes people look at Connecticut and saying, the problem is us. And the reality is the problem is nationwide. The problem is in every state. And some of it is just the natural course of the work. It's inherent. But some of it is the pandemic. And I suspect we're going to take several years to come out of the pandemic. I also know that in other New England states, they don't have that budget, but they are, the last meeting we had was month before last, and most of their directors actually do cases, and they're not on call for hours at a time. They're on call for days at a time. So they do on call, and it's not just for a few hours. So we are actually in, compared to some, we're actually in a good place. It may not seem that way, but we are certainly not alone.
Yeah, perspective is always good.
Yeah,
Denise,
so we're not alone.
Denise, you referenced $1 million facility for Massachusetts. When you talk about facility, what is that, their administrative building? Or when you say facility, what do you mean?
No, facility it was very specific to their Telesane program. It was built for it. It was modified for it. Telesane, and this is not a conversation about Telesane, but the bottom line here is that there's a lot more behind the curtain, if you will, about that. You have to have an environment that is very neutral. That kind of thing.
$1 million is part of their overall $7 million budget, and that's specifically directed to Telesane services.
It's part of that is grant funding. In addition to, they get grants in addition to their money, their line item.
Thank you.
But to go back to the model, their original model was that they had safe designated, or in their state it's SANE. So they had SANE designated sites where if where they were concentrated in those facilities, and if a hospital, if an ambulance was called for a victim of sexual assault, it might bypass one hospital that was not SANE designated for one that is. So that's been their model for some time. So I hope that answers the question. So any other comments? I mean, I think this has been a great discussion, and I don't want to bring it to a conclusion if there's other comments that people would like to make, observations.
Yeah, I just want to say about the other sites. I know that, for example, the Yale Health Plan was designated, even though it's not a hospital, they have an urgent care, and so they were designated as an acute care site. So at some point they were able to do them there. And I don't know, again, it would be a lot easier for universities to have someone on call, if they are, if they have a full service student healthcare center that's considered an acute care of the option, and that would be another way. And that would also mean all the urgent cares in the state who meet the designation of an acute care facility, in theory, would be able to collect evidence. I think there'd be a lot of, at all the random urgent cares, I think there would be a lot of logistics issues, but I certainly think the student healthcare plans, if we can make sure that they're legally allowed to do it, I think they'd be great places, because the students have follow-up. They may feel, welcome and trusted, and have transportation and all the important things for access.
Yes, that's certainly, for the student population, absolutely. We've kind of had conversations with UConn and the Storrs campus about that aspect of things, and how to be medically cleared and all of that. Because medical clearance, they had a tendency to have they had to be more conservative with that. Any other thoughts?
Well, I would just like to add, when Denise stepped away and the conversation was just beginning, there was kind of a question of, do we at ODS have a different vision of what the program should look like? And the answer to that is no. Our vision is that every patient who presents with sexual assault receives compassionate and appropriate care by a trained medical provider. So that is our goal. And this conversation has been so helpful. Certainly, we recognize that we have barriers both in attaining medical providers as safes and then in retaining medical providers as safes. And so having this conversation about what are the barriers in both of those arenas, getting medical providers interested and able to take advantage of the training programs. And then once we have those trained medical providers, how do we retain them as trained safes within our state? So we are so thankful for the conversation and for so many of the ideas that were generated today. And we recognize it's just the beginning of that conversation as we look for alternatives to reach that goal where all patients that present have access to that care.
Yeah. So with that said, we do have one more item on our agenda, and as Mary said, we're going to continue this discussion. I'm going to go back and on a side note, I will go back and I want to revisit some of our points and see if I can pull some of these thoughts together. But in conclusion, and we do have one more thing, and that's new business. And I know we have a plate full, but does the committee, the question on the table is, does the committee have any new recommendations to consider that they would like the committee to consider? Okay, and hearing none. So I want to thank all of you for a really robust meeting. It's been a great conversation. And I'll make a note that our last meeting of this year is on November 8th from 2 to 3:30, and it will continue to be virtual. Just again, on a side note, this will be, the November meeting will be my last meeting as I am retiring in December. And so, but I know that the good work is just beginning. So thank you all, and we will adjourn at 3:19.
Thanks, Denise. Thanks, everyone.
Thank you.
Thank you, everyone.
Thank you.